Every day, you essentially pay your dues by doing the harder thing when it's the right thing to do. There's two big buckets here, like your hip is normal shaped, your hip is over coveraged and has issues because of that, or it's under coveraged and has issues because of that, right? Most people in the normal range don't have problems. The Warwick Agreement is the big thing that kind of came out for FAI and some other things related to intra-articular pathology, and they outlined some really good concepts for what classifies somebody as having FAI and what we would clinically want to see that, right? So clinical imaging has to be present, also have to have symptoms, right? A lot of people have asymptomatic labral tears, or they have changes on osseous morphology that, you know, it's just them and it never bothers them. So it has to be symptomatic. It has to match the clinical rules of tests that rule in, like a Scour test or a Fader test. And then also they like to see sometimes that a cortical injection or a diagnostic injection alleviates their symptoms intra-articularly for them to be ruled in that they have a pathology that the hip joint is the issue for, right? You can have someone who doesn't have that much pain, who doesn't have imaging changes like a cam or a pincher, and their diagnostic injection doesn't make their hip feel better when it goes into the joint. It's probably just something extra articular that happens to be also bugging them in a similar area. And once we start layering the anatomy on top of each other, it makes a lot of sense of like why somebody's hip could bug them, but it could be like literally a structure on the next layer up, like the labrum, the ligaments, some soft tissue and tendons, and then muscular stuff is literally all in this little triangle space. So you have so many things that could be aggravated in the same spot that we need tools to figure out, is this intra or extra articular, or is this like coming from a contractile layer or coming from something inside the hip joint that needs a surgery or something to be repaired. So that's why it's very hard to wrap your head around sometimes. Right. So you can think about that mechanism of all those different ways and why the anatomy matters, because again, repeated extension and anterior tipping, right, is one mechanism. Only in gymnasts or dancers or weird people like I work with, if I laterally go so much, I can tip inferiorly. So I can go out to the side, hit the lateral wall, and inferiorly sublux, or inferiorly put stress on an inferior labral tissue, right? Think like a 6 o'clock lesion, a 3 to 6 o'clock lesion, versus the extension rotation person is like a 11 to 3 o'clock lesion, a slap tear, a classic slap tear. Okay, so you're hitting and you're subluxing. Laterally, you're hitting and you're subluxing down, and you don't really sublux posteriorly because your hip has so much flexibility and it's made to flex really, really deep, but there's contact between the front. Yeah? So that's the idea with hips that are very, very different, is when a lot of our special tests happen, and the shoulder and apprehension test is really provoking just straight up sliding off the glenoid. Versus in the hip, some of the tests we might be doing for apprehension or instability are really based on the opposite, like pushing somebody out the front because of so much hyperextension or lateral wall contact. Okay. As you move backwards, what can we do to change the load and the range of motion? We could do a counterbalance box squat. So instead of holding the weight, they're pressing out so it gets more hip drive back, keeping a vertical shin. And then a bodyweight squat would probably be the next regression. And then lastly, if someone's really needing help, we would do a TRX assisted box squat. So taking off a lot of the percentage on their hands, dropping them to a box. So progression-wise, goblet squat without the box is probably just the most logical progression. Is squat a little deeper, make sure that the foot position looks pretty good and they feel comfortable. With a load, they can just linearly load. Front squat and then box jumps and stuff, you start to get more into like sports performance of power displacement. So pogo hops, vertical hops, seated box jumps, all that kind of stuff. And then for the last bit, right, the most far you're probably getting somebody is like a back squat, seated dumbbell jumps, some more explosive type vertical movements, depth drops, all that kind of stuff to load the hip quite a bit. So split pelvis, I think the entry point for most people is just going to be a basic dumbbell split squat, and also sleds. I think sled work is extremely useful and beneficial for people who have hip and knee issues as well, but particularly hip issues, because you can change the load, you can change how pitched they are, you can have them toe versus push. You can also do lateral sled drag work, which is in the accessory section. But some sort of a dumbbell split squat and a push or a pull of a sled is where my head is going to. Somebody who can't tolerate that, I'm trying to get them to a bodyweight split squat, to just a couple AirX pads or 1 or 2 AirX pads. Past that, change the motion even more, add more AirX pads and just do their body weight. And then all the way back down at the end is going to be a TRX assisted split squat, just like the squat, right? Take a lot of pressure off their arms, restrict the range of motion. So after surgery, like someone who's having hip surgery and stuff, after the first initial damage control phase, one of the first things I give them is a 2 AirX pad TRX split squat, because they can really control how much hand they are for comfort level, and they literally just like boop, boop. It's like this like small little range of motion where they usually feel okay, and we're not putting too much flexion on the front leg. Okay, and then ideal entry point after that going forward, dumbbell split squats or dumbbell lunges are probably where we're looking at. I think typically you'd want to have someone do a forward lunge first, that's more of the knee, right, versus someone doing a reverse lunge is more of the hip. That would be opposite in the knee. If somebody had an ACL or a patellar tendon issue or something cartilage-wise, I'd do a reverse lunge first to load the hip, I would do a forward lunge second, because that's more knee pressure as they step onto that leg in the front, which there's some pretty good data to support the forward lunge versus reverse lunge. And then I would keep doing the sled, but I would either change the components of more load or more speed based on their sport. So someone who's a strength athlete, I might load the sled up heavier and have it be a slow marching push, versus someone who's a speed athlete, I might keep the weight relatively low and just try to get down the turf faster. And then lastly, all the way to the end. So personally for me, bilateral elevated dumbbell split squats are probably like one of the hardest things you can give somebody. They're horrible, but they elevate the front leg quite a bit to put you into more flexion, and they demand quite a bit more of your back leg. So in the first section of 2, you could just elevate the front foot or just elevate the back foot if you're trying to put someone into more hip flexion or less hip flexion based on if they're FAI, you might want to progress into the flexion of their front leg a little slower, versus if somebody has more of like an issue with the back hamstring area, you want to be careful of too much loading in the front leg because you might put them into a deep position of flexion. All right, and then all the speed and agility sprinting stuff kind of I think falls into the split pelvis position of change of direction, sprinting, all that kind of stuff, acceleration-wise. Yes? Knee dominant versus hip dominant. So front squats are more of an upright torso, just like a goblet squat is. So someone's going to load their knees more and have less hip pressure, versus when you back squat somebody, it tips their torso forward and puts more drive on their hip. So you get more anterior tipping and anterior trunk lean, but also you're more of a hip dominant squat. So then you have like even a low bar versus a high bar back squat, you could argue is more or less hip dominant. But somebody who is goblet squatting or front squatting, you can really keep them upright and just squat to a box, and it's very, very knee dominant. As soon as you put someone in a back squat and tip this way and you drive their hips back, it loads the back quite a bit, but it also compresses the front possibly quite a bit more. So yeah, and again, that would be reversed if somebody had knee pathology and we're trying to spare the knee a little bit.